Hello friends, it's pleasure to have you back on the channel of Clinical Care Insight. We started a series of lecture on antipsychotic drugs, or also called as the drugs which is basically used to manage the mental illness. Okay, in our previous lecture we have seen that what actually is the drugs which we are using in the management of mental illness. Commonly we called that branch of the pharmacology, okay, which is used to manage the mental illness, we call that psychopharmacology. And the drug which is used, we call that drug as, very good, psychotropic drugs. Fine. Depending upon the use, the psychotropic drugs are classified in different categories. Okay, we seen that some of the drug which manage basically the depression, we term those drugs as antidepressant. We also seen that there are certain diseases where the you can say there is an extreme elevation of the mood, okay, hyperfunctionality. We term those disease mania. So for management of mania, we have the anti-manic drugs. Then we also seen that there are certain drugs which manage the psychosis, okay, and we termed those medicine as an antipsychotic medicine. Fine. Now, in our today's lecture, we will discuss about that. We already seen that the antipsychotic drugs are used to manage the psychosis, okay, and mainly these antipsychotic drugs are used to manage the schizophrenia and some of the schizophrenic affective disorder, the mood disorder. We also seen that there are two classes of antipsychotic drugs. The one class is called as the classical drugs, which is discovered initially. We term those drugs as a typical drugs. Why it is called typical? Because they typically manage the positive symptoms of schizophrenia, that is hallucination and delusion. Then in other hand, we discussed about that there are certain drugs which have the less side effect as compared to the classic or typical medicine, okay, and they first of all they exert the less side effect, and the other thing is that these drugs, okay, they manage not only the positive symptoms, they also manage the negative symptoms. Now what are the negative symptoms? Probably you recall the negative symptoms, that is loss of motivation, okay, flattening of the emotion termed as the adonia, okay, and social isolation, social withdrawal, okay, and there is excessive mood fluctuation. Fine. So these are called as the negative symptoms. So there are something called positive symptom and negative system. The fundamental difference between these two categories of antipsychotic drug is that the typical antipsychotic drugs manage typically the positive symptoms, whereas the advantage of this atypical drug is that these drugs not only manage the positive symptoms, they also manage the negative symptoms. Then we also seen the, you can say, common indication where we are using those antipsychotic drugs. We've seen we are using these drugs in the case of mania, we are using these drugs in the case of schizophrenia, we're using these drugs in the case of depression, okay, anxiety. Fine. And also we discussed that there are certain drugs which is, you can say, the hallucinating drugs. So we already discussed these things. We also discussed some of the, you can say, concept about the typical and atypical antipsychotic drugs. Now here in today's lecture, we have the detailed discussion over the typical and atypical antipsychotics. We will see that what are the, you can say, the adverse effect or side effect of these typical antipsychotic drugs, because this is a worth to discussing, because once you start administrating these antipsychotic drugs, remember, as I discussed in the previous lecture, that these antipsychotic drugs, they are not present over the counter, they are not over the counter medicine, okay, they are properly prescribed by the psychiatrist, okay, and then only they will available. Now in this lecture we will discuss that the typical antipsychotic drugs, okay, these drugs have so many side effects. These drugs have so many side effects, and we will see one by one each, okay. Now, as we discussed in our previous lecture, that these typical antipsychotic drugs, okay, these drugs are basically the dopamine receptor 2, D2 antagonist. First of all, this thing you should clear in your mind, that the typical antipsychotic drugs are D2 antagonist. Fine, no problem. Now, the main problem with these drugs is that they are less expensive. First of all, remember, these typical antipsychotic drugs, if we take the comparison with the atypical antipsychotic drugs, then it is a less expensive and it is widely available, first thing. But the underlying problem of this typical antipsychotic drug is that they are only, first of all, managing, okay, managing the positive symptoms of schizophrenia, that is hallucination, okay, hallucination, you can say the thought disturbance management, fine, and delusion. These things, only the positive symptoms is managed by this drug. Now the main problem, the main challenge, once you start these drugs in the patient, okay, then patients have something called as side effects. Side effects. And these side effects is very much, you can say, needed to understand, just because sometimes if you not manage the side effect of these drugs, okay, it will take away the life of a patient. It can be the life-threatening situation. It's a fatal. Are you getting the point? Okay. So first we will see that where these D2 receptors are present in the brain, in the center. Of course, this is we are discussing the drugs which is used to manage the mental illness. Okay. So we will see first that where this D2 antagonist receptor is present, fine. And then we will see that what is actually the action of this typical antipsychotic drug. So for that, you just concentrate on one diagram. This is your central nervous system typical diagram, okay? And here, you know that for the, you can say for memory formation, first thing, another thing is for the thought, you can say thought regulation, for your emotion regulation, got it? Your anger regulations, these all are done in the one specific part in the brain, okay? And that system is referred as a limbic system. That is referred as a limbic system. Okay, this is the one, you can say, diagrammatical view of your limbic system. Limbic system is concerned with regulation of your mood, regulation of your behavior, your thought pattern, okay? And along with the hippocampus, it's also help to retain the memory, okay? It also have to, you can say, form the memory, fine? So this is a function of limbic system. And remember, in the case of schizophrenia, what is happening? There is a severe thought disturbance, okay? There is a severe thought disturbance. Person also have the problem in perception. Okay, there is something called false belief. Okay, false belief. These things is just because due to the problem in this limbic part of our brain. Okay. So in the midbrain region is also called as the mesencephalon. So in the midbrain region, there are some, you can say, nuclei called as ventral tegmental nucleus. Ventral tegmental area or nucleus, fine. This ventral tegmental area which is present in the midbrain, it have the dopaminergic neurons. What kind of neurons? Yeah, it have the dopaminergic neurons which project to the limbic system, Okay, so limbic system will receive this dopaminergic neurons. Got it? No problem? Now, the main theory, you can say the classical theory which some extent explain the pathogenesis of schizophrenia is the dopaminergic hypothesis, is the dopamine hypothesis. Write it down. Okay, this is called as the dopamine hypothesis. Dopamine hypothesis. This dopamine hypothesis states that here in this region, this, you can say, this projection, this pathway, okay, this is called as the mesolimbic pathway. Suppose, as I said you, this nucleus is present in the mesencephalon, that is actually a midbrain region. So meson, take the word mes, and this is the limbic region. So it is called as the mesolimbic pathway, and mesolimbic pathway is a dopaminergic pathway. So this pathway is called as the mesolimbic pathway. Got it? No problem? Now, so what is happening in this mesolimbic you can say limbic pathway, there is a auto inhibition. Okay, there is a auto inhibition of dopamine secretion. Okay, dopamine secretion, or you can say the dopamine production in the limbic region. And you know, if the dopamine is less in the limbic region, then person will not have the normal, you can say, thought. Their thought pattern is absolutely disturbed. Then limbic system is also concerned with the perception. Okay, so patient have the hallucination. Okay, patient have the delusion. So negative symptoms, fine, sorry, the positive symptoms, because these symptoms is not present normally in the patient. This is added in the you can say person personality. So these are called as the positive symptoms. So positive symptoms in the case of schizophrenia is due to the, you can say, the hypofunctionality of this mesolimbic pathway. Okay, hypofunctionality of this mesolimbic pathway. That's the first thing. Now, the another thing, okay, the another pathway, another dopaminergic pathway which is present here is in the prefrontal cortex area, this area. Okay, this is called as the prefrontal cortex area. This area is actually concerned with our mood regulation. Okay, this area is concerned with our motivation. Okay, and you can say the social well-being, motivation, okay, and also for mood regulation. These three things are, you can say, basically a function of this frontal area. Okay, prefrontal area, this is the function. And here also there is a, you can say, nuclei which is present here, and these nuclei have the dopaminergic neurons which project here, which project in this area. And you know, as I said you, that dopamine is actually an inhibitory hormone. Dopamine is actually an inhibitory hormone. And here what is happening, there is a hyper, you can say, secretion of the dopamine, hyper secretion of the dopamine, or you can say the hypersynthesis of dopamine in the you can say the cortex area. Okay, prefrontal cortex area, and it lead to the elevation in the mood. The patient's mood is disturbed so much, got it, and there is a isolation, and there is a loss of motivation. Okay, loss of motivation. And because you know that generally the motivation, good mood, okay, and the social well-being, it is present in a one person personality. Okay, but here it is what? It is lacking. So that's why it is called as the negative symptom of the schizophrenia. So from onward, you just remember that in the case of normal person, now I am talking about the healthy person. In the case of healthy person, there should be balance. Okay, there should be balance between the two brain area, at least first. One area is called as the mesolimbic area. Okay, mesolimbic area. All right. Now, the another area which should be the balance with this mesolimbic area is your mesocortical area. This pathway is called as the mesocortical pathway. Okay, this is called as the mesocortical pathway. Okay, mesocortical pathway. It should be balanced with the mesocortical pathway. This is the mesolimbic and mesocortical pathway. But this modern theory which explains the schizophrenia, it states that there is a, you can say, the lower functionality in the mesolimbic area, and there is a over functionality, or you can say the hyper secretion of the dopamine in mesocortical area. It lead to the schizophrenic, you can say, situation. And there are evidences in favor of this hypothesis. We support this hypothesis. Okay. And the thing which you should remember is that there is an imbalance. Okay, generally there should be the balance, but in the case of schizophrenia, here what is happening, here is there's a less secretion in the mesolimbic, you can say, the pathway, and there's a hyper secretion in the mesocortical pathway, which lead to the positive and the negative symptom respectively. No problem. Now, once we understand you can say, the basic pathogenesis of the schizophrenic condition, let's apply with the drug. So, as I said you, that the most of the typical antipsychotic drugs, okay, or you can make one generalization, that is, all the antipsychotic drugs work on D2 receptor. All the antipsychotic drugs are D2 antagonist, first of all. All the antipsychotic drugs are D2 antagonist. So here it must be presence of D2 receptor, and here also there is a presence of D2 receptor. So both the category, take the example, take the example of the typical and atypical, both the drugs will bind, okay, both the drugs will bind over this receptor, but this binding affinity is different. The binding affinity is different. The typical antipsychotic drugs bind with the D2 receptor very tightly, okay, whereas the atypical antipsychotic drugs, they will also bind with the D2 receptor, but that binding is transient. That affinity is actually a transient affinity, a weak affinity. Got it? Now let's apply the first with the typical antipsychotic drugs. Once you give the antipsychotic drugs to the patient, okay, here these drugs will bind over the D2 receptor, okay, and there is a blockage, okay, there is a blockage, and patient have the, you can say, the patient, this positive symptoms is menace, patient positive symptom, that is the hallucination, you can say the thought disturbance, delusion, these things are menace after the administration of these typical antipsychotic, or also called as the classical drugs. Got it? But you know that dopaminergic pathway or neurons are not only present with this limbic area. Dopaminergic neurons are also present in different area. Okay. You check this channel Clinical Care Insight playlist. You will find the two disease, the two neurodegenerative disease which I will discuss. Already I discussed in the detail. The first is called as the Alzheimer disease. Another one is called as the Parkinson's disease. Okay. So in the case of Parkinson's disease is basically, okay, it is actually a motor abnormalities, okay. So in the case of this Parkinson's disease, okay, there is a you can say the disturbance in the dopamine secretion. There is a disturbance in the dopamine secretion which lead to the different psychotic, you can say the motor abnormalities first of all. So here what is happening, you are only targeting this mesolimbic area, but unfortunately these drugs will also inhibit, you can say, the dopaminergic pathway, which is basically concerned with regulation of movement, okay. So you inhibiting those pathways, then patient will develop the Parkinson's-like syndrome. Got it? And these symptoms are actually called as a group, they are called as the extrapyramidal side effect. They are called as the extrapyramidal side effects. And it is very, actually these side effects have to manage promptly, okay, on spot. Otherwise it will, you can say, cause a very much harm to the patient, or sometimes you can say it's create a life-threatening situation. So they all are called as the extrapyramidal side effect. Now what are the extrapyramidal side effects? You know that Parkinson's-like symptoms. What is the symptoms of classical presentation, hallmark of Parkinson's disease? You remember? The one is tremor. All right. Another is, yeah, rigidity of muscle. Or there is a hypokinesia, difficulty in initiating a movement. Patient have the tremor with the rigidity, okay, with hypokinesia, akinesia. Fine. Sometimes also patient develop the dystonia, okay, the catatonic situation where all the muscle is frozen hours to hours, okay, in a one position, patient will arrest. Fine. So these are the, you can say, the side effect. Apart from it, these antipsychotic drugs, they also, you can say, disrupt one pathway, okay, basically one endocrine pathway. You know that there is a presence of hypothalamus. There is a presence of hypothalamus, and below to this hypothalamus, there is a presence of, yeah, there is a presence of pituitary gland, anterior pituitary and posterior pituitary, okay. Then you know that the anterior pituitary have many, you can say, secretion of many hormones, and one of the hormones is the prolactin. So the lactoferrous cells, okay, called as the lactotropes, which basically is synthesizing the, yeah, which is synthesizing the prolactin, and this also have the dopaminergic neurons. So these drugs, okay, will bind over here, okay, and causes the galactorrhea, okay, galactorrhea and gynecostomatia. Two things. I'm pronouncing maybe in a wrong way, but you just understand. It's called as the galactorrhea and gynecostomatia in the male, okay, galactorrhea and the gynecomastia. And sometimes, okay, sometimes it also causes the infertility, but infertility are rare, but these two symptoms are prominent in the case of administering as a side effect of the typical antipsychotic drugs. Are you understanding? Then there are also the other, you can say, problems related with this side effect of these antipsychotic drugs, and that is patients develop another kind of problem, okay, and that is called as the malignant, okay, neuroleptic syndrome. Malignant neuroleptic syndrome. Now here what is happening, patients have the fever, okay, along with there is a, you can say, problem in the muscle, okay, patient have the high secretion of myoglobin in the blood as well as in the urine, okay, the blood pressure will fluctuate, heart rate is fluctuated, okay, and there is also hypovolemic shock. This is just because as a side effect of these typical antipsychotic drugs. No problem. Now, in the later state, in the advanced stage, there is another side effect, okay, which is actually related with the extrapyramidal side effect, that is called as the tardive dyskinesia. Tardive dyskinesia. Now, this tardive word means late, okay. This is actually a, you can say, problem which occurs in the late phase of this schizophrenic patient. Once patient is started after 1 year, 2 years, okay, they all are in the antipsychotic drug, then these symptoms will arise and mostly it's affect the older lady. In this case, what is happening? There is a, you can say, abnormal movement in this oreocortical area, okay, oreocatharoid area, this you can say lip area. There is an abnormal movement of the lip, jaw, fine. There is abnormal, you can say, movement of the tongue, fine. These are called as the tardive dyskinesia symptoms, and this arises as a side effect of the, you can say, administration of the typical antipsychotic drugs. So these are the side effects. Once again, what are the side effects? Basically, the side effect is, you can say, categorized as an extrapyramidal side effect, okay. And here patient have the Parkinson's-like disease symptoms, patient have the tardive dyskinesia, patient have the malignant neuroleptic syndrome, and also patient will develop the galactorrhea along with the gynecostomatia, along with it person have sometime occasionally the infertility. So these are the broader, you can say, the side effects, okay. And sometimes, but that's a rare, that's called the miscellaneous, you can say, side effect, and that is as a hypersensitivity. That is not related with the course of drugs that patient develop. That's a hyper, you can say, sensitivity. So these are the typical antipsychotic drug side effects. You clear with the mechanism, okay. For the mechanism, just remember this diagram, that there is the axis, you can see the less function or less secretion of dopamine in mesocortical area, or there is a hyper secretion of the dopamine in the mesocortical area, lead to the positive and negative symptoms. All the antipsychotic drugs is binding over the D2 receptor, all are the D2 antagonists, okay, but the affinity varies. In the case of typical antipsychotic drugs, they bind very strongly with the D2 receptor, okay, and strongly, you can say, clear out the positive symptoms, okay, but they fail to manage the negative symptoms. Now, we will move ahead and discuss that why atypical drugs will not, you can say, not produce these fatal side effects. Why? Now let's discuss.